Good afternoon, guys. This afternoon's topic B is the title is Caring for a Parent Who is uh, Resistant to Care, um, in, uh, Incooperative. Okay, so we're going to go through that today for B. So please join me for B's presentation. Here we go. Here's a summary of the page's main points. Story overview. The letter comes from a concerned daughter who, in her 40s, who's struggling to care for her 74-year-old mother, who lives alone and insists she's fine despite showing signs of physical and cognitive decline. Health concerns. The mother has serious health issues: high blood pressure, diabetes, arthritis. She won't consistently take her medications or visit a doctor. Has refused screenings and lab work for years. Shows potential early signs of dementia, e.g., getting lost, forgetting appointments, resistance to help. Daughter's efforts like installing grab bars, meal deliveries, and attending appointments are met with firm rejection. Mother resists. She's not an invalid, which makes interventions difficult. Expert recommendations ignored. A neurologist recommended further testing, but the mother never followed through. Core conflict. The daughter is torn between honoring her mother's independence and trying to prevent potential crisis like falls or hospitalizations. Okay. She's emotionally drained and seeks guidance. Would you like to delve into solutions for situations like this, perhaps through the lens of frailty aware care or shared decision making frameworks that align well with your expertise? Managing chronic health issues effectively means creating a care plan that that that's adaptive, person centered, and respectful of autonomy, especially when resistance to help is part of the equation, like in the case of the mother on the page. Here are some strategies that blend particularly or practically uh, practical and compassionate approaches, holistic frameworks, frailty aware care models, customized care based on vulnerability levels, not, hold on, folks, just diagnosis. This allows for proactive adjustments before crisis occurs. Shared decision making. Invite the individual to co-design their care, giving space for values, preferences, and dignity to be honored. Environmental design. Memory-friendly housing. Incorporate intuitive layouts, visual cues, and smart tech that supports independence without feeling uh, intrusive. Ambient assisted living. Use predictive technologies that monitor health passively and alert caregivers to subtle declines without overwhelming the individual. Behavioral and therapeutic integration. Therapeutic layering combines CBT, dance therapy, mindfulness, or occupational therapy tailored to specific chronic conditions, especially cognitive decline. Alternative therapies explore neuroplasticity driven rehab or nutritional strategies that support anti inflammatory and neuroprotective functions. Caregiver, caregiver empowerment, boundary setting tools offer caregivers resources to support self care and ethical navigation of autonomy versus safety. Death doula integration, if relevant, can shift toward emotional resilience, resonance, and dignity in later stages while addressing external concerns. Would you like to break down any of these strategies into action plan for specific scenarios, like supporting someone who refuses medical care or designing a smarter home that feels like a sanctuary rather than surveillance? Absolutely. Shared decision making, or SDM, is a collaborative process in which healthcare providers and patients or caregivers work together to make health decisions that align with the patient's values, preferences, and goals. It's especially vital in frailty aware cognitivity and sensitivity contexts, like the one we discussed on the page. Core principles of SDM: respect for autonomy, recognizes the person as the ultimate decision maker. Even if cognitivity impaired with proper supports. Manual exchanges. Clinicians offer expertise. Patients, caregivers offer personal insights, values, and lived experience. Transparency. Risk, benefits, and uncertainties of each option are clearly outlined. No sugarcoating or jargon. Deliberation time. Decisions don't have to be immediate. The pace adjusts to the person's readiness and comprehension level. Models that support SDM: three talk model, team talk, build partnership, and outline choices. Option talk: compare risks and benefits. Decision talk: arrive at a shared plan. Decision aids: virtual tools and guides that simplify options, especially helpful for individuals with memory or attention challenges. SDM: frailty aware and memory friendly environments. Cognitive scaffolding: simplify complex choices with cues, repeated information, and resulting rituals. Content and comfort: decisions like refusing screenings or meds aren't seen as obstinate, but potential expressions of discomfort or fear. Family involved SDM: particularly effective when the individual resists formal medical screenings. Caregivers can co-navigate options with clinicians. Would you like a breakdown of how this could be applied to a specific scenario, like the mother's refusal of medical tests, and how her daughter could navigate that conversation collaboratively? Certainly. Here's a grounded example of shared decision making, SDM in action. Tailored to the mother, daughter situation we discussed. Scenario: medication refusal background. Okay. The mother is refusing to take her diabetes and blood pressure medications. Consistently, her daughter is worried but doesn't want to override her mother's autonomy. Step by step shared decision making flow. Action: daughter and trusted clinician, e.g., geriatrician, establish a collaborative tone. They acknowledge the mother's independence and concerns. You're not an invalid. You deserve options. Now this is them talking to the mother, guys, in the scenario. Okay. Okay, clinician explains clearly what happens if meds are skipped, what lifestyle alternatives exist, and what minimal interventions like reducing pill burden or timing adjustments might help. The mother is invited to choose from the options. Maybe she agrees to take one key medication if it's once a day and in a gummy form, less intrusive, more tolerable. The daughter supports that choice while keeping tabs on early signs of decline. Okay, memory friendly enhancements. Visual pill tracker placed on the fridge. Short short reminder notes written in the mother's own handwriting to preserve familiarity. Positive reinforcement rituals, celebrating good days together. This kind of SDM doesn't guarantee full compliance, but it builds trust and reduces emotional gridlock. Want to sketch out how SDM might uh, guide end of life care decision or use smart home cues to reinforce autonomy. We could explore that next. Implementing shared decision making, SDM, effectively, especially in frailty aware, memory sensitive environments, requires a combination of thoughtfully designed tools that relational strategies. Here's a breakdown of high impact options: cognitive and virtual aids, decision grids or matrix, sample charts that compare options based on risks, benefits, and personal values, alignment, uh, graphic rich booklets or pictograms help convey choices to individuals with limited verbal processing or early cognitive decline. Okay, guys, for those folks with cognitive decline, you still have to integrate them. So using cue cards or pictures to communicate your uh, conversation with them. Pictures are great for those who don't communicate well. Okay. Okay. Narrative based tools, story driven formats that present real life scenarios to foster empathy and clarity. Clinical tech based tools, Ottawa Personal Decision, Ottawa Personal Decision Guide, or OPDG, promotes reflection on values and helps assess decisional conflict. Ask 3 questions. A structured prompt encouraging patients to ask, what are my options? What are the risks slash benefits? And what does this mean for me? Digitally, digital, digitally guided SM or SDM platforms, apps, and online portals that walk users through decisions using layered info and check ins, especially useful for younger caregivers supporting older adults. Behavior algorithms in ambient assisted living setups. They can offer uh, unobtrusive insights into a person's readiness or our ability to engage with certain decisions. Caregiver focused resources, conversation coaching guides help caregivers initiate SDM dialogues, especially when facing resistance or emotional fatigue. Frailty SDM frameworks account for uh, fluctuating capacity, adjust pace and detail accordingly. Ethical triage charts. Prioritize decisions when urgency, dignity, and safety correlated, particularly used for long-term care or crisis management. Memory-friendly enhancements. Using familiar routines or rituals, e.g., having choice time after morning tea. Include repetitive cues and anchoring phrases like this. This is about what feels best for you. Would you like a custom toolkit sketch for a caregiver navigating end of life planning in a memory friendly home, or an example of how to use these aids in clinical consults? I can tailor it to your focus on autonomy and systematic healthcare reform. Implementing shared decision making, or SDM, in clinical settings, especially within frailty aware or memory sensitivity care, requires more than just offering choices. It calls for deeply intentional communication, ethical clarity, and structural support. Here's a breakdown of the best practices that align with both clinical rigor and person-centered care. Structural foundations and embedded SDM workflow. Integrate into intake forms, care planning sessions, and interdisciplinary rounds. Don't treat it as a bonus or time permitting option. Use decision aids. Provide evidence-based visual initiative tools tailored to cognitive capacity and health literacy, e.g., pictogram booklets, digital apps, value certification charts. Create SDM documentation templates. Log the progress, transparency values, expressed options, discussed and final choice. Useful for community and quality audits. Clinician skill building. Training for value ethical relation. Go beyond what you do. What do you want? To what does a good day look like for you? Or what trade-offs feel most manageable? Practice scenario deliberation. Role play complex choices, especially where safety and autonomy clash, such as refusing medication or choosing palliative care. Adapting communication styles, using cognitive scaffolding for individuals with memory loss, slower speech, repetition, visuals, and simplifying jargon. Relational and ethical grounding, honor fluctuating capacity for frailty or neurodegeneration, acknowledge that decision-making ability may vary day to day, offer revisits and a reassurance. Use supported decision-making models. Okay. Engage family or advocates, not to override decisions, but to amplify comprehension and agency. Incorporate cultural and emotional resilience. Understand how spiritual beliefs, past experiences, and familiar roles influence preferences. Environmental enhancements. Memory-friendly consult spaces. Reduce sensory overload with muted lighting, consistent layouts, and virtual queuing systems. Ambient tech integration. Passive monitoring tools like moment trackers or voice agents can flag changes. That prompt SDM engagement early before crisis. Would it help to sketch out an SDM implementation guide tailored to a geriatric implementation guide tailored to geriatric outpatient clinic or smart home contexts? I can thread in caregiving, collaboration, tech ethics, and digitally preserving rituals. Okay, guys, I'll be back on with C shortly. Till then, Gator Wellness, take care, folks.